Shock, by definition, is a failure of the cardiovascular system to deliver enough oxygen and nutrients to meet cellular metabolic needs. There's a number of causes of shock. One, which we're going to discuss in this lecture, is called hypovolemic shock due to a decrease in blood volume. The other forms of shock are cardiogenic shock due to poor heart function, vascular shock due to inappropriate blood vessel diameter, and finally obstructive shock due to the obstruction of blood flow. So let's look at hypovolemic shock. You'll notice that this appears to be a very complicated figure, but we're going to break it down into really three interconnecting pathways. But let's first look at the stimulus. The stimulus is hypovolemic shock. The controlled condition is blood volume and blood pressure. So hypovolemic shock is due to low blood volume and low blood pressure. Before we get to these specific paths, if you look down at the bottom of the figure, you'll notice the responses. The responses should always make sense when looking and comparing to the stimulus. If the stimulus was low volume and low pressure, notice what the responses are. Increasing blood volume, increasing vascular resistance to keep the pressure up, and that will eventually bring us back to homeostasis. So this is a negative feedback mechanism in response to hypovolemic shock. So how do we get there? You'll notice that one way to get there is the renin-angiotensin-aldosterone system. That begins with the kidney detecting this hypovolemic shock and low blood pressure. In response to that, releasing renin, so when renin goes into the bloodstream and activates the pathway. You'll notice the lungs and liver are on this figure as well. They're involved in production of many of the enzymes involved in the pathway. One of them being ACE, angiotensin converting enzyme, which is actually produced by the lungs, which converts angiotensin 1 into angiotensin 2. So there we have angiotensin 2 in the bloodstream. And what it's going to do is, one, stimulate the adrenal cortex to produce aldosterone. Two, if we follow this arrow, angiotensin 2 is a vasoconstrictor. And that vasoconstriction is going to help increase vascular resistance, which increases blood pressure. So you'll notice this is just the renin-angiotensin-aldosterone system on the figure. The next one you'll see is the nervous system. So there we have baroreceptors in the carotids and aorta monitoring blood pressure, notifying the cardiovascular center of your medulla oblongata using vagus and glossopharyngeal nerves, and then the cardiovascular control center affecting the heart, increasing cardiac output using sympathetic activity, and then also vasoconstricting blood vessels. So you notice vasoconstriction of blood vessels is a response of both of these pathways. And then finally, right in the center, we have ADH, which we already know ADH, produced in response to low volume or dehydration, and ADH having two major functions: increasing blood volume by retaining water and vasoconstriction. So it's all on there. It's many different responses to hypovolemic shock. You'll notice that this is largely a summary figure. We've done all this up until now. The next part of this video, let's just go over quickly some of the different pulse points on the body. So a pulse point requires an artery, an elastic artery, to be palpated. You must be able to feel the artery just beneath the skin. So these are, in essence, some of the more superficial arteries that you can feel stretching and recoiling in response to systolic and diastolic blood pressure. And some of these you've probably known that you can take a pulse. The carotid arteries are very common. Radial artery is a really good one to palpate. Femoral, behind the knee, the popliteal artery. And there's an artery right on top of the foot called the dorsal artery of the foot. That is also a very common pulse point. Next thing, taking blood pressure. Taking blood pressure is something that you'll probably have to do when you move on into your medical program like nursing school. We're not going to necessarily do it in class, but I want you to know the theory behind blood pressure. First thing is we use an artery. You always take blood pressure in a systemic artery unless you're trying to determine pulmonary blood pressure, which is a little more tricky because you can't palpate the pulmonary artery. But you can use a number of different arteries. Obviously, this is the brachial artery. It's the most commonly used artery to measure blood pressure. You need a couple instruments. You need a stethoscope, and what you're listening for is blood flow and then the disruption of blood flow. You also need an instrument called a sphygmomanometer, or commonly just referred to as the cuff. So there's different panels here we're going to walk through. First panel is an artery. It's the brachial artery. You don't have the sphygmomanometer on it, and blood is flowing freely through that artery. If we were to put that stethoscope and listen, we wouldn't hear anything. You do not hear blood flow in an artery that is wide open. Then we pump the cuff, the sphygmomanometer, up to well over systolic blood pressure. So you have to inflate that cup up to 160 or 180 millimeters mercury. What that will do is close off the brachial artery. And when you close off the brachial artery and listen to it, you don't hear any blood flow because there is no blood flow. So the question is, what moment will blood start to flow through that artery again? And that happens when you let the pressure out of the cuff, and the moment the pressure equals systolic blood pressure, blood begins to flow again. That first sound of blood flow is called the first Korotkoff sound. So the moment that blood starts to be forced back through that artery, you can hear the swishing of the blood through the artery. That marks the pressure during systolic contraction, ventricular contraction, because that's the pressure that forces that blood back through that artery. And you'll continue to hear these sounds until that artery is opened again. So when the pressure in the cuff equals diastolic pressure, the sounds go away. So what you're listening for is a swishing sound of blood through a slightly compressed artery. Because if the artery is closed completely, you don't hear any blood flow. If the artery is open completely, you don't hear any blood flow. You only hear the blood swishing through the artery when the artery is being squeezed. So this is how we take blood pressure. The next set of lectures are going to cover all the different systemic arteries that you're responsible for knowing, and then the systemic veins. So from here on forward, it's all about identification of blood vessels.